Good afternoon,
Cystotomy.
dear colleagues, ladies and gentlemen. It is my pleasure to be the only delegate veterinary surgeon joining this World Laparoscopic Congress. I will present my modest experience in this rapidly global exploring era of laparoscopic and robotic surgical science. So I will present a comparative study by cystotomy by laparoscopic techniques in dogs performed by two techniques, by intracorporeal and laparoscopic-assisted technique. Right. So the aims of this study was to compare between two techniques, laparoscopic and laparoscopic-assisted techniques for experimental creation of full thickness defects on the urinary bladder wall in dogs as a model. And secondly was to compare between two suture techniques. One is the titanium clips versus one full thickness simple interrupted pattern with polygalactine 910 for repair of the created defect in the wall. The study was a pure experimental surgical study performed on dogs on 18 adult animals from both sexes. Their age ranged from 9 to 3.5 years and body weight 15 to 25 kgs. The animals were divided randomly and equally into three groups. The first, laparoscopic cystoscopy and UB wall defect, was closed by intracorporeal technique using titanium clips. While the second group, laparoscopic-assisted cystoscopy, was performed and the UB was closed extracorporeally by one full layer thickness of simple interrupted using the 30 polygalactine 900 or by other mean Vikram. The third group was laparoscopic cystoscopy performed as in group 1, intracorporeal I mean, but the bladder was closed instead of titanium, was closed by the Vikram. So the surgical procedure was a routine one where the animals all pre-medicated and generally anesthetized using pre-medicament and ketamine. The animal fixed on dorsal recumbency and aseptic urethral catheterization produced.
Yes, Dr. Pradeep Garg.
This is another fibroid which I am just removing.
There is another
I just want
fiber.
to show you that this is also very large fibroid.
Okay.
Which I will remove. Now you can continue the lecture. Once I will remove and suture, then I will come back to you.
Okay. So you can please show or no? I think okay. You continue, please. You continue.
Continue your lecture.
Okay.
And then I will come back to you.
Okay. Sir.
Sorry for the interruption.
That's all right. And the ventral abdomen was prepared for aseptic laparoscopic cystoscopy, routinely as that. So, number one, of course, routinely, the Verse needle was inserted bluntly into the abdomen cavity and pneumoperitoneum was produced. And then that was replaced, the Verse needle was replaced by the laparoscopic trocar cannula. And pneumoperitoneum, of course, continued. In group 1, an extra 3 portals B, C, and D were produced on the ventral abdomen. Well, usually the B and C were for the graspers, and the D was for the laparoscopic scissor or the needle holder. In this case, D was used, from the D portal, the laparoscopic titanium clips holder was introduced. Before that, full thickness 1 to 1.5 centimeter was created on the bladder wall, and then the scissor was replaced by the titanium clips applicator, and about 3 to 4 in the maximum of titanium clips were applied on the bladder wall to repair the defect. In group 2, at which cystoscopy was performed by laparoscopic-assisted technique, a second portal was made caudal to the umbilical port. And that was, of course, the only port through which the laparoscopic instrumentations were introduced, where first we introduced the grasper, and the trigger of the bladder was grasped and held close to the abdominal wall. And then later, this portal, B portal, was transferred into a mini laparotomy incision, where of course, in female animals, it was on the mid-ventral, but in female, it was para-median because of the prepuce. So when the bladder was extracted, it was fixed by 2 retention sutures, and routine conventional cystotomy was performed on it by scalpel, and then the incision was enlarged to about 2 to 3 centimeters, and then sutured conventionally by using vicryl suture, full thickness, of course. Right, the last group where laparoscopy was performed totally intracorporeal, where, of course, again, 3 other portals were created on the ventral abdominal wall, as it is seen on the figures, C, D, and B. C and B were the portals from where the instruments that grasp and fix the bladder were used to introduce through, while the T portal was the portal through which the laparoscopic scissor and then the laparoscopic needle holder and the surgical thread was introduced through it, and intracorporeal suturing of the bladder defect was created, as it is seen in this figure. Right. The results of this comparative study techniques between 2 laparoscopic techniques, fortunately, all the operated dogs survived until they were sacrificed at 15 and 30 days. Well, the sacrification was to follow the healing process of the UBs and to grade the extensiveness of the adhesion produced intraperitoneally. And of course, these dogs were followed by cystography at 7th, 15th, and 30th, where positive and negative radiography was performed on the urinary bladders, and from the 7th onward, none of the bladders showed leakage or urine fistula. This is the cystography of one of the dogs in group 1, at which we used titanium clips to close the defect. Unfortunately, this group, signs of nidus formation or cystolithiasis were possibly diagnosed on these dogs because of the high oxalate salt level in the urine post the 13th of postoperative day. But this was only in one dog out of the 8 in this group. Group 2, the laparoscopic technique was considered from our view, the best as a veterinarian, I'm talking, because the cystoscopy conducted within much shorter time, the UB was exercised easily and safely, and the technique allowed the proper examination of the cavity of the bladder and the urethral opening. And finally, the extracorporeal repair of the bladder defect by the one-layer FTSI pattern was performed much more easily and perfectly compared to the intracorporeal. And finally, the results in group 3, although the outcoming results were, the full intracorporeal laparoscopy with using Vicryl to close the defect, were the best on necropsy where none of the animals showed intraperitoneal adhesion formation. But this technique needed high skill for the intracorporeal suturing and knotting, and it was a bit time consuming.
Can you summarize?
Yes, it is. I finished, sir. So, in conclusion, generally the laparoscopic cystotomy by both techniques were minimally invasive and safe. Secondly, laparoscopic cystotomy was the easier technique because it provided easy access, maximal UB exploration, and simpler cystotomy repairs. And finally, the intracorporeal closure of UB wall by both methods were secure, but the titanium clips may cause urolith formation, while suturing by Vicryl produced excellent results, but time consuming and needed skill. Thank you very much for your attention.